Margaret Calloway arrived at Mercy General Hospital at 5:45 every morning. Not because her shift started at 6, because she liked the quiet. She liked the way the ER felt before the world fully woke up. The hum of the lights, the soft beeping of monitors down the hall, the smell of floor cleaner and recycled air. She made her coffee, checked her assigned patients, and prepared herself the same way every single day, quietly, completely, without anyone noticing. That was how she preferred it. She was 38 years old, medium height, with short dark hair and steady brown eyes that did not miss much. She spoke when there was something worth saying. She laughed when something was genuinely funny. She did not perform either. Among the nurses at Mercy General, she was known for two things: being extremely good at her job and being extremely difficult to know. 4 years on the floor, and most people still called her Calloway, because she had never invited anything more personal than that. The morning that changed everything started like any other. Dr. Preston Hale walked into the break room at 6:15, thermos in hand, already talking. He was the kind of man who filled rooms, not with warmth exactly, but with volume. He was 44, chief attending in the ER, trained at the best schools, and he carried that fact like a badge pinned to his chest at all times. He was not a cruel man. He was something slightly different, and, in some ways, harder to deal with. A man who had simply never been taught to look carefully at the people around him. Margaret was at the far end of the table, rolling her sleeve back down after fixing a small cut on her forearm. The motion was brief, but not brief enough. Hale glanced over. He saw the tattoo. It was old and faded, dark ink on pale skin, a trident above a cracked skull, a number, and below that, one word in block letters: Echo. "What is that?" he said. He was not being unkind. He was simply not thinking. Some kind of tribal design? Or was there a biker phase we don't know about? He smiled at the two residents standing nearby. Some people let their 20s make permanent decisions. There was a short ripple of uncertain laughter from the residents, the kind that comes from young people who are not sure whether to laugh, but also do not want to be left out. Margaret did not look up. She finished rolling her sleeve down, picked up her coffee, and took a sip. She said nothing. There was no anger in her face, no embarrassment, no reaction at all, just the same steady expression she wore every day, which most people mistook for distance, and which was actually something else entirely. She went back to work. If you had asked anyone in that break room that morning what they knew about Margaret Calloway, they would have given you very little. She was a good nurse, reliable, calm in a crisis, kept to herself. That was the whole picture, as far as any of them were concerned. None of them knew where she had come from before nursing school. None of them had ever asked. She deflected personal questions with a small smile, and a redirect so smooth that people usually did not notice they had been redirected at all. There was a reason for that. 16 years before that morning, Margaret Calloway had not been a nurse. She had been a Navy corpsman, a military medic, embedded with a special operations unit in a part of the world that did not appear on any public mission record. She was among a small number of women serving in a forward support role during a period when the rules about such things were quietly changing. The unit she worked with operated in places that were not officially acknowledged. They did things that were not officially recorded. Her call sign was Echo. The SEALs gave it to her not as a joke, but as a real name, earned in the field. They called her Echo because she seemed to anticipate what was needed before anyone said it aloud. She knew which man was about to drop before he dropped. She had supplies in her hands before the request came. She finished the thought before the sentence was complete. In a combat environment, that kind of attention is not a personality trait. It is a survival tool, and she had sharpened it until it had an edge. In 14 months, she kept 6 men alive who had no medical reason to still be breathing. On her final deployment, a unit movement was hit by an ambush near a dry riverbed at dusk. 2 members of the team were killed immediately. 3 others were critically injured. Margaret was the only medic on the ground. There was no backup. There was no way to call for anything that would arrive in time to matter. For 47 minutes she worked. She performed 2 emergency procedures that most fully equipped surgeons would hesitate to attempt in a proper operating room, using the supplies she had in her pack and nothing else. One of those procedures she had never performed on a living person before that evening. She performed it by feel, by knowledge, and by the specific kind of calm that lives on the other side of fear, not the absence of fear, but the decision to keep moving through it. The extraction helicopters arrived 47 minutes after the ambush began. All 3 critically injured operators were alive when they were loaded onto the aircraft. She received a formal commendation. It was classified. It went into a file that the public would never see. She left the Navy the following year, enrolled in a registered nursing program, and stepped into civilian life without announcement. She did not talk about her service. She did not share her history. She let people assume what they assumed, and she moved forward. The tattoo was the only visible remnant of that time. It had been given to her by the team, a mark of belonging to something that had no official name and left no official record. She had never removed it. She simply kept it covered. Back in the present, the morning after the break room incident moved the way most mornings in a trauma ER move. Fast, loud, and without pause for anything as small as feelings. Margaret worked her assignments. Dr. Hale ran his rounds. The residents made small mistakes and were corrected loudly. The charge nurses kept everything from collapsing under its own weight. At 10:20, the call came through the radio and then immediately through the charge nurse's phone. Mass casualty protocol. Standby. Multiple inbound. Unknown incident. ETA uncertain. The ER shifted frequency the way it always did when a real emergency arrived. Not louder, but denser. Every movement became deliberate. Every conversation shortened to its essential words. Margaret was already moving before anyone told her to. She repositioned 2 crash carts. She cleared trauma bays without being asked. She called the blood bank on the mass casualty protocol code, a step that sits 3 items down a checklist most people had not reached yet. She moved with the quiet efficiency of someone who had done this before, not in a hospital, but in conditions that a hospital was designed to approximate. Dr. Hale noticed from across the room. He walked over. Calloway, who authorized the blood bank call? Protocol 4C, Dr. Hale. Mass casualty prep. We don't know the nature of the inbound yet. No, she said simply. We don't. He looked at her for a moment. Then he moved on. At 10:41, 2 helicopters landed on the hospital's rooftop pad. The pad was rarely used. It existed for the most severe civilian transfers, and even then, it saw action only a few times a year. Today, the aircraft that landed there were not civilian. They were military. They carried no visible markings. 2 of the people who stepped out of them were in full tactical gear, armed, and moved with the particular posture of people who are trained never to be surprised. A Navy commander in civilian clothes came through the ER doors at a controlled walk, quick without running, the walk of someone who was urgent but disciplined about it. He had identification clipped to his jacket. He went directly to the charge nurse and explained, in brief and precise language, what he needed. He needed their best trauma nurse, not a doctor first, a nurse. Specifically, if available, someone with combat medicine experience. The charge nurse blinked. The request was unusual. She looked across the floor, scanning automatically, and her eyes landed on Margaret. Margaret was already crossing the room toward him. The commander looked at her. Something moved across his face. A flicker of recognition, or something very close to it. His eyes dropped briefly to the name on her badge. They came back up to her face. Echo? He said. The word was quiet enough that only she could hear it. She held his eyes. What do we have, Commander? He told her. 4 casualties from a training exercise that had gone badly wrong. A mechanical failure during an airborne operation had caused an emergency landing with injuries. 2 operators with severe trauma, one developing a dangerous pressure condition in his chest during transit, one with serious damage to a blood vessel in his leg. They had bypassed 2 closer hospitals for a specific reason. One of the men in the most critical condition had a documented severe reaction to a standard medication used in emergency resuscitation. That reaction, 5 years earlier, had nearly killed him. His medical file flagged Mercy General as the nearest facility, with an alternative protocol on record, a protocol that had been submitted to the hospital database 3 years ago through a continuing medical education filing. Margaret had written that filing. She had submitted it quietly, citing patient-type scenarios without personal explanation. No one at the hospital had known why she knew what she knew. She turned toward the trauma bay and began. The next hour and a half was not the kind of medicine that gets written up in hospital newsletters or discussed at staff appreciation events. It was technical and precise and, from the outside, almost unremarkable in its steadiness. Margaret moved without rushing. She called for medications by their alternatives before the attending physician could finish looking them up. She walked a resident through a procedure with a voice so even and clear that the resident performed it correctly on the first attempt. She tracked 4 patients simultaneously and kept the status of each one in her head with a completeness that required no chart reference. At one point, Dr. Hale entered the trauma bay. He came in with the authority of a chief attending, ready to take primary responsibility. The commander stepped into his path, not aggressively, not dramatically. He simply stopped him with one hand, gently but completely. "She has it," the commander said. Hale looked past him at Margaret. She did not look back. She was already solving the next problem. All 4 men survived. By 1:30 in the afternoon, the helicopters were gone. The commander shook Margaret's hand before he left, both of his hands around hers, the kind of handshake that means something more than a handshake. He spoke to her too quietly for anyone nearby to hear. She nodded once. He left. The ER returned to its regular pace, but something in the room had shifted. It was not something that could be pointed to directly. It was in the way people moved around Margaret now, slightly differently than before. It was in the way the 2 residents who had laughed in the break room that morning found reasons to look at their shoes. It was in the way the senior nurses, who had always known something was different about Calloway without knowing what, now held that knowledge in a new shape. Dr. Preston Hale stood at the nursing station for a long time after it was over. He stood there, and he did not speak. Later, when the shift was nearly finished, he found Margaret in the break room. Same chair, same coffee, same silence. He sat down across from her. He was quiet for a moment, which was not something that came naturally to him. "The tattoo," he said. She looked at him. "Those men upstairs called you Echo." She said nothing. She waited. "I owe you an apology," he said. She looked at him with an expression that was not warm and was not cold. It was direct. It was honest. It was the expression of someone who had long since stopped needing things from people that they were not yet ready to give. "You owe your patients better attention," she said. "That is all." She finished her coffee. She stood up. She went back to work. She never told her story to anyone at the hospital, not to the administrator who called her in a week later to ask about the incident, not to the local news outlet that somehow caught a fragment of the story and called the PR line. The official hospital statement described a routine inter-facility transfer, and that was all anyone outside the ER walls ever knew. The tattoo stayed covered, but something permanent had taken root at Mercy General. New nurses were pulled aside by the older ones and told, without drama or ceremony, to watch how Calloway moved in a trauma bay, to listen when she spoke, to understand that the quietest person in the room is not the least important one, that a person who does not explain themselves is not a person with nothing to say. And Margaret Calloway kept showing up, every morning at 5:45, coffee made, patients checked, ready before anyone else arrived, sleeves down, eyes steady, always the first one ready, always the last one anyone truly knew.